This is Command Post, a series of discussions about military matters from Time and the Center for a New American Security.
Meg, in the military, people talk about the stigma of seeking mental health care. Has your research shown that that stigma in any way gets in the way of suicide prevention efforts?
It does, and I should point out that stigma about mental health care isn't unique to the military, but what is unique to the military is that individuals work and obtain medical services from the same overall system, and they're very concerned, to the extent that they perceive the stigma, that if they seek care, that it will be reported back to their unit. So individuals that perceive the stigma may be afraid to seek care. They may not be able to afford care outside the military, and the people around them, their commanders and their peer group, may not be aware that they're having difficulties and that they need help.
But implied in your answer is the fact that if it does get reported back to their commander, that's going to hurt them. Is that true? I thought the Army was making a big push to say, hey, you can, seek all the help you need and we'll welcome you back.
Clearly, the most senior officers have spoken out on this issue, to include Admiral Mullen when he was chairman. There's uncertainty, though, from basic soldiers out there whether their own command has the same attitude and whether they'll be welcome to seek care, and the stigma still exists. And again, it's not unique to the military, but the military is a very different culture, and one in which that tough it out attitude is going to persist.
I think there's also been enough instances where somebody did go seek treatment and other people found out, and that person's career, maybe it wasn't over, but they weren't allowed to deploy with their unit, so that people are legitimately concerned. One thing you find when you look at it is that younger soldiers are very worried about what their buddies will think, while more senior soldiers are worried about the effect on their career and if they're going to be able to get a security clearance when they retire from the military. And most contractors require a security clearance, so you don't want to do anything.
I recently reapplied for my security clearance and noticed that the question had changed, that I did not have to write down treatment I might have received for mental health problems resulting from deployment.
Right, but there's still enough uncertainty about that and what it means, and again, anecdotal times of people whose security clearance was delayed, that people don't want to seek treatment. Now, again, the Army has done some good things about that. So they started Military One Source, there's an online counseling, there's a number of other venues where somebody can go and seek treatment, but there's uncertainty about what you can do and what you can't do, and that is a big barrier.
2010 was the first year that of those service members who died by suicide, the majority of them had sought care in a military treatment facility in the month before they died.
And that's been a real change. We're screening a lot more people with our post-deployment health assessment and reassessment and periodic health assessment. So we're getting more into the mental health system, but just getting into the mental health system doesn't mean that you're protected from suicide. So it used to be the belief was get them to the shrink, and now it's got to be more than just get them to the chaplain or the doctor. It's got to be how can the unit and the family take care of this person over the long term.
But Meg's point about 2010 is quite interesting, because what it means is if you get them to the doctor, they still kill themselves, right?
They may still kill themselves.
They may.
I mean, that's pretty disconcerting. How effective is counseling in preventing suicide?
I do a lot of lectures where I focus on what can you do in 1 to 2 sessions to decrease suicide, because most service members are not going to come for 10 or 20 or 30 sessions, which is what's often recommended in the civilian literature. And so the intervention has to be something that helps bring the soldier into that cohesive, nurturing environment, and again, often has the unit and or the family as part of the solution set.